Welcome. Today we're going to talk about HIV and AIDS, epidemiology, testing, and regulations. This is the first module for the Qualified Professional Test Counselor certification course. My name is Philip Chan, and I will walk you through this lecture. So the outline of today's talk is a basic introduction to HIV/AIDS. We're going to cover the epidemiology of HIV, the pathogenesis and transmission, diagnosis, management, and treatment. This is the core lecture, and this is really what the basis of a lot of counseling that we give to patients. So therefore, it's important to understand these aspects of HIV. Certainly no one who goes through this course will be an expert, but it's important to have the basic concepts down so that you can provide accurate and reliable counseling to patients. As always, certainly if you don't know the answer to the questions, you should feel free to contact myself or other people in the state that are experts in the matter. As I mentioned, really one of the main purposes of this course is to promote education and awareness about HIV and give you the basic counseling skills to educate others. Understanding the HIV test results and what it means and how to effectively communicate that to others, and also provide a basis for effective prevention counseling. In terms of some basic definitions, when we talk about HIV, we're talking about the human immunodeficiency virus. This is a virus that attacks the immune system for people. Over time, the virus degrades a person's immune system, eventually leading to AIDS, acquired immunodeficiency syndrome. This means that a person's immune system is no longer functioning and that they can get sick with other infections. It's never HIV itself that actually kills a person. It's that HIV depletes one's immune system so that they get sick from other infections. However, people who have HIV are started on highly active antiretroviral therapy. This is a combination of medicines that prevents the progression of HIV to AIDS, thus prolonging life. And one of the key concepts, as well as one of the key counseling points, is that people who are diagnosed early and go on HAART have a normal life expectancy. And we'll talk a little bit more about this later in the lecture. The key concept is that AIDS is a disease caused by HIV. So the epidemiology of HIV. As we look at HIV across the world, approximately 37 million people are currently living with HIV/AIDS. You can see the percent of people in different countries. There's a lot of focus on people with HIV in sub-Saharan Africa, and you can see why that is, the dark blue of the map here. Over 10% of people in some of these countries walking down the street are infected with HIV. In the United States, that tends to be around 0.3%. So you can see how HIV disproportionately affects a lot of other countries in the world. As I mentioned, in the United States, there's about 1.2 million people. That comes out to about 0.3% of the population in the United States. Importantly, about 20% of people are undiagnosed and unaware that they are actually infected. This is one of the key groups of people that we want to make aware of their infections. Also of note is that because people are no longer dying and living longer due to the medications, the people living with HIV continues to exponentially increase. Typically, we talk about a number of groups of people who are more at risk of HIV. This has to do with biological factors, transmission factors, as well as HIV tends to circulate within different networks of these individuals. One group that we talk about are gay, bisexual, and other men who have sex with men. In the medical and public health world, we often refer to behaviors and not sexual orientation. So, for example, there could be a person, a guy who identifies as straight, yet has sex with other men. So in terms of a clinical definition, we talk about men who have sex with men, which encompasses men that identify as gay or bisexual. Also, traditional at-risk HIV populations include people that use injection drugs, people who exchange sex for money or drugs, people who have sex with an HIV-positive partner, and people who have sex with partners who are either MSM or injection drug users. As we look at the HIV across the United States of America, we can see again that there are certain areas that are disproportionately impacted. Here in Rhode Island, you can see light blue here tends to be a lower incidence state. A lot of HIV tends to affect the Deep South, some of the major urban centers, of course, in the Northeast and West Coast as well. When we look at what populations are most impacted by HIV across the U.S., it really tends to be men who have sex with men. When you look at the number 1, 2, and 3 groups, it's really Black, White, and Hispanic, Latino, MSM. Importantly, Black and Hispanic Latino MSM are disproportionately infected with HIV. So that is important in terms of identifying different racial and ethnic disproportionate risks. After MSM, you can see that Black women, Black men, heterosexual contact are the next, followed by white women, heterosexual contact. This is why it's incredibly important, especially when we talk about MSM, to really talk about HIV prevention with this group and really be able to identify risk factors associated with HIV infection. When we look in for at least the 2014 data across the United States, we see that about 67+% of all new HIV diagnoses were due to male-to-male sexual contact. You can see injection drug use was 6%, heterosexual contact was 24%, and it's the estimated number of new infections among MSM also continues to increase. So this has been a priority population and one that we need to focus on, including here in Rhode Island. These are some of the same numbers that we see across our state as well. When we look at age group, HIV tends to predominantly affect those young adults, 25, 20s, and 30s. You can see here the major risk groups are between 13 and 24, 25 to 34, with another slight bump into their 35 to 44 age group. I'd like to show this slide too because it reminds people that HIV is still a significant cause of mortality in the United States. So if you look at the far right column first, you can see that these are the traditional causes of mortality in the United States. Number 1 up there is heart disease, number 2 cancer, et cetera, et cetera. But as you start to look at lower age groups, those in their 20s and 30s, you can see that HIV is still a major cause of mortality in the United States. And I think that this is really important to visualize to remind us all that HIV is still a significant cause of mortality here in the U.S. So Rhode Island, what does HIV look like in Rhode Island? So again, in the state, there's about 1.1 million people. There's an estimated to be about 2,500 people living with HIV in Rhode Island. Every year, there's approximately 100 people that are diagnosed with HIV. Again, Rhode Island in general is considered a relatively lower incidence HIV state, and through 2011, there's been about 3,000 AIDS cases reported in general. Overall, we've done a good job addressing HIV in Rhode Island. The number of cases over the last decade has significantly decreased, and actually in 2015 it's a little bit lower. This has been due to a number of different HIV prevention interventions that we've had throughout our state. We have really good harm reduction and syringe exchange programs. We have really good mother-to-child transmission screening programs, so all pregnant women are screened for HIV, and we have a number of community-based HIV programs as well. So we really believe that a number of those approaches have led to lower HIV over time. Looking at the number of people living with HIV in Rhode Island, you can see that it's increased. So as I mentioned, people are dying a lot less from HIV due to the advancement of medications and heart. You can see that as time goes on, the number of people actually living with HIV in Rhode Island continues to increase. Similar to the national statistics, as you look at the risk groups and the groups of people in Rhode Island infected with HIV, it tends to really impact gay, bisexual, and other men who have sex with men. You can see the dark blue line here, about 50 to 60% plus of all new HIV cases in Rhode Island tend to be MSM. When we look at gender, you can see that men tend to be disproportionately impacted. You can see that women are much less affected here in Rhode Island. In terms of age groups, these also parallel the national statistics, where we tend to see people in their 20s, 30s, early 40s tend to be those most likely to be diagnosed with HIV. In Rhode Island, we also see a disproportionate number of new infections among racial and ethnic groups, specifically Black African American and Hispanic Latinos. You can see that Black African Americans are disproportionately impacted, as well as Hispanic Latinos, compared to white non-Hispanic individuals. When we look at age groups among MSM, you can see that younger MSM are significantly impacted by HIV, specifically those 13 to 19, 20 to 29. You can see there's a disproportionate increase among younger MSM. This is also reflected nationally and has been a group that's been there's been a lot of focus and discussion about. When we look at HIV incidence among men by exposure category, again, you can see that really by the pink lines here, the MSM really more and above from any risk group are those most likely to be infected with HIV. You can see that overall we've done a good job addressing AIDS. So again, people really one of the goals of providing early HIV testing is to diagnose people early and prevent progression to AIDS, which is when the immune system is severely depleted. You can see that the number of HIV cases progressing to AIDS and death in Rhode Island is low and has overall decreased in recent years. This slide describes the risk groups over time here in Rhode Island since the early 90s. You can see that we've done a good job, especially a good job among injection drug users. So in the late 90s here, these are when some of the harm reduction programs targeting injection drug users were implemented, specifically needle exchange programs, as well as improving accessibility to syringes. And you can see the dramatic impact this has had over time with decreasing new HIV cases in this group. At the same time, you can see among MSM, although it's decreased overall, it certainly remains stable, and there's been a slight uptick in recent years. To summarize HIV infection in Rhode Island, MSM are the predominant risk group. Approximately 50-60% plus of all new cases are among MSM. The rates of new HIV diagnoses have decreased overall, but have also remained unchanged in the last few years. Different racial ethnic minority groups, specifically African American and Hispanic Latino groups, are disproportionately affected by HIV. That is the case across the United States as well as in Rhode Island. And younger age groups are also disproportionately affected by HIV. Pathogenesis and transmission of HIV. This is the natural history and typical course of HIV. In general, it takes approximately an average of 6 to 8 years when someone is first infected with HIV before they progress to AIDS. During this time, they may have absolutely no symptoms. This is one of the huge difficulties in addressing the HIV epidemic, is because when people are first infected, they may have no symptoms for years and years and years and may be transmitting HIV unknowingly to others during that time. You can see with the black line here, that represents the number of CD4 cells in a person. The CD4 cells are a marker of the immune system. You can see a person with a normal immune system has a CD4 cell count of 1,000. It in general ranges anywhere from 600 to 1,000 plus. You can see over time, over a course of years with that black line, it decreases as HIV attacks the immune system. The red line here is the viral load. So that's the number, if you look at the right-hand y-axis, that's the HIV RNA. That's the number of viral load HIV particles. You can see that in a given cc of blood, when someone is first infected over the first few weeks, that really spikes up. That's a period known as acute HIV infection. That is when HIV is really out of control in the body when someone is first infected. What happens then actually is that your immune system does get a measure of control over HIV, and you can see that that red line comes down, it dips down. It means that HIV viral load does decrease slightly. However, in the long run, it's a losing battle with HIV, and eventually the HIV overcomes the immune system and then spikes up in the late courses of disease. Again, people do not die from HIV or AIDS. They die because they get their immune system is depleted enough where they get other infections. You can see the black arrow here identifying when people tend to get other infections labeled as opportunistic infections. Another important aspect of HIV is that it really tends to affect all tissues and organs of the body, from the brain to the colon to the lung, etc. HIV can really cause a whole range of symptoms and manifestations across the entire body systems. One of the important things to note, and this will occasionally come up in counseling, is how to tell when someone actually gets HIV. So one of the questions that we often get is, do people feel sick when they first get HIV? And the answer is yes, oftentimes. Unfortunately, though, when people get sick, they tend to have a flu-like syndrome. I tend to ask people how many people in the audience have had a flu-like syndrome in the last year, and pretty much everyone raises their hand. Again, it's very common. People generally may not remember it, and it's very tough to distinguish from a common cold or other flu-like symptoms in general. However, when they do look at it, and there's a number of studies to describe this, people do tend to have some symptoms when they first get HIV. These are the symptoms that they tend to get. You can see fever, lymphadenopathy, which means increased lymph nodes, especially around the neck and throat, pharyngitis, which means sore throat, rash. This can be something that's relatively uncommon in other flu-like diseases. However, it can be a little bit more common in acute HIV. Myalgias, muscle aches, arthralgias, joint aches, diarrhea, headache, etc. So a lot of these things are very non-specific, and people will get during the course of the year, people without HIV will get a couple things that may clue you in, especially though is thrush. So that's a fungal infection of the tongue, usually presents as sort of a whitish coat along the tongue. That can be one of the classic presenting symptoms of HIV and should certainly necessitate an HIV test. As I just mentioned, the natural history of HIV, people tend to, when they do have symptoms, it's known as retroviral syndrome. It tends to occur within the first few weeks of infection. What happens is people then undergo what's known as seroconversion. That means that they develop antibodies to HIV. Antibodies are the things in your body that actually fight the infection. That is important because when we talk about HIV testing, the antibodies are the things that you actually measure to tell if you have HIV. What that means is that during that first 2 to 4 weeks before you develop antibodies, sometimes the HIV test will be negative, and that's known as a window period. That's really a critical counseling point because sometimes people may tell you that they had a high-risk exposure last week, and they may still be in the window period of the HIV test. Therefore, the HIV test may be negative even if they have HIV. Most people convert to having HIV antibodies, which means that the test is usually positive within the first 6 to 12 weeks of having HIV. As I mentioned, the average progression to AIDS is 6 to 8 years, although it can be variable. We do see people that are termed long-term non-progressors, and that's about 4 to 7%. These are people that do not progress to AIDS or progress to AIDS over decades, many years. Likewise, there's also a group of people known as rapid progressors. Those are people that progress to AIDS over 1 to 2 years. So there's a lot of variability within how long people progress to AIDS, although the average time is about 6 years. There's also a really interesting group of people known as elite controllers. This is about 1 out of every 300 people, less than 1%. These are people that have specific variations of their immune system that actually allow them to control HIV. So these are people that have essentially normal immune system. They have no symptoms. It's difficult to detect virus in them, yet they are known to have HIV. And the reason they don't have any virus or have very little virus is because their immune system is especially tuned to HIV, and there's some genetic variation that allows them to control HIV better than the general population. These are some of the possible signs and symptoms of chronic HIV infection. As I mentioned, thrush, or the fungal infection of the mouth and tongue, is really one of the classic ones. People may also have significant unexplained weight loss, as well as feverish chills, sweats during the night. People may have dementia or cognitive decline, not being as sharp as they used to be. Unexplained lymphadenopathy, so nodes, lumps, or bumps around the neck or throat region. Neuropathy, shingles or zoster, which is a reactivation of chickenpox. People may also have certain cancers and other AIDS-defining illnesses. When does someone have AIDS? So as I mentioned, a normal CD4 cell count, which is a measure of the immune system, tends to be when someone has a CD4 count between 600 plus up to 1,000. When that becomes less than 200, that's really when you're at risk of getting other opportunistic infections. So that's really the number to remember when your CD4 count is less than 200. And these are the number of AIDS-defining illnesses. So these opportunistic infections. These are a list of diseases that you can get when your immune system is suppressed. Again, these are things that are sort of circulating in the environment and our normal immune systems are able to fight off. But once your immune system becomes below a certain level, you're much more likely to get a list of these. This is sort of a rehash of the previous graph here. You can see again over time, between anywhere from 6 to 8 up to 10 years, your immune system CD4 counts will decrease, as well as your viral load will increase over time. People generally develop AIDS between 8 to 10 years, and they can survive years afterwards. However, you're much more at risk of getting opportunistic infections and dying from that. What is the risk of contracting HIV from an infected partner? So this is a question that we get a lot, certainly in the course of education and counseling. Really, the highest risk is receptive anal sex. So what that means is that if you are a person having anal sex, if you are the person, if the person with the penis is HIV positive and that's being inserted into the rectum, and the person who's having the receptive sex is HIV negative, the risk has been described as approximately 3%. So that is the highest risk for HIV infection. And this is per act. I will note that these numbers are historically difficult to determine, and there can be a wide variability. They can also, your risk of HIV can also be due to a number of other factors. For example, if there's other STDs present, depending on one's viral load. But in general, having receptive anal sex, which we tend to refer to as bottoming, tends to have the highest HIV risk. You can see here for vaginal sex that the risk is 1%. If you are the person with the vagina or the person with the penis having vaginal sex, the risk tends to be less than 1%. You can see for needle sharing, for injecting drug use, the risk is also tends to be less than 1%. The highest risk overall would be receiving a direct transfusion of HIV tainted blood, with the risk of that being 90 to 100%, which should make sense. To summarize, a person is diagnosed as having AIDS when their CD4 cell count, marker of the immune system, is less than 200 cells per cc, or they have a CD4 cell percent less than 14%, or they have an AIDS-defining illness. The other important note is that all people aged 15 to 65 years should be tested for HIV, and we'll talk about this for a little bit more later on. Diagnosis of HIV. So who should be tested for HIV? So all the major medicine groups, clinical groups, really recommend that everyone should have an HIV test at least once in their lifetime. You can see here the CDC recommends everyone aged 13 to 64. The U.S. Preventative Task Force, which is one of the major primary care guidelines in the United States, recommends people should be tested from 15 to 65. But the bottom line is that everyone should be offered routine HIV testing at least once if they're in this age group, and at least once a year if they're sexually active, and possibly more frequently if they have increasing risk factors. The rationale for routine HIV testing in general is that it reduces stigma, it improves finding cases of HIV, and getting people on treatment improves outcomes, and we'll talk a little bit more about that as well. Some of the other reasons to promote routine HIV testing is that just knowing one's status can lead to less risky behavior. If someone knows that they're HIV positive, they're going to be less likely, in general, to have condomless sex or otherwise. And they've also done a number of economic studies which have shown that, in general, doing HIV testing is cost effective due to the high cost of treating someone with HIV. So how do we diagnose someone with HIV? As I mentioned, we'll go over this in much more detail in future lectures. However, most of the HIV tests, and the ones that we'll be testing here in this class, deal with looking to antibodies for HIV. So antibodies are, again, the things in your body that react to infections, react to HIV, and they can generally be detected 2 to 8 weeks after an infection. These tests can also be called ELISA tests, enzyme-linked immunosorbent assays. All these tests tend to be very sensitive. What that means is that they're able to detect even the slightest hint of HIV, but it also means that sometimes they're so sensitive is that they detect things that are not HIV. Because of that, all HIV tests are confirmed by secondary tests. You can see here the one that is used in Rhode Island and tends to be one of the most common is what's known as a Western blot test. It's another test that looks at HIV antibodies as well as HIV antigens, and it tends to be just a little bit different methodology. We can also measure things, the exact viral load of HIV. This is especially effective if we have someone that we suspect has acute HIV infection. We can actually measure the HIV viral load. This graph demonstrates what happens when someone is first infected with HIV. You can see the line here labeled RNA is the HIV virus itself. You can see that when someone is first infected, that naturally peaks and then levels off. You can see that there's a second dotted line here called the P24 antigen. The P24 antigen is a part of the HIV virus. You can see it's actually what surrounds the HIV virus itself. And you can see that we now have some tests that actually detect the P24 antigen and that we can detect HIV earlier. You can see the final dotted line labeled antibody is when the HIV antibody tends to appear, and they tend to appear about 28 days after you're first infected with HIV. So it's really critical to tell people that in general these tests tend to detect HIV several weeks after you may have been infected. So that's important to keep in mind when counseling someone. When people are first infected, it's also important a lot of times when you counsel people to determine if they've had any symptoms of acute HIV. Again, these are flu-like symptoms. A lot of times, though, if you ask people early enough, they will remember it and they will say it's bad. People who may have really severe cases, and they may say that they especially have a lot of lymph nodes. Again, rashes may be present, as well as significant fevers. This is the classic HIV testing algorithm, including the one that we use in Rhode Island. This is what happens sort of after you test someone. You can see the very first test at the top here, labeled HIV 1/2. EIA is a test that is what the rapid tests are and what a lot of people will perform in the field, including the ones that we'll teach you in this class. If that is positive, then that gets reflexed, confirmed by an HIV-1 Western blot test. If that's positive, then you are called HIV positive. If that's negative, then we do check a couple other tests to try to describe why the tests were discordant. These are all the FDA-approved rapid tests on the market. In this class, we'll be talking about the OraQuick by OraSure. It is important to note there's a number of other tests out there, and they are all accurate and work well and are all approved by the FDA. We'll talk much more about this in later lectures, but it's important when someone has a positive HIV test, especially when they have that first positive antibody test, is to let them know that this is a preliminary positive test, and it does not necessarily mean they have HIV. We all see, for those of us who've been doing this long enough, we all see a number of both false positive and false negative tests. So a false negative test means that the person actually has HIV, but the antibody test is negative. The most common cause of this by far and away is that the person actually has acute HIV infection, which means that you're testing them in this window period and they have not developed antibodies yet. So I know I keep hammering that point home, but it's really important to try as best as possible to identify these people if you can. There's also a number of different HIV subtypes around the world. The tests in general are very good at picking up all these different HIV types and subtypes. However, it's important to be aware of if you have people, especially from Africa and especially from Western Africa, they may have types of HIV that may be occasionally missed from the test. Certainly, if there's any questions about this, you should refer to an HIV specialist. Rare causes of false negative HIV tests include immunosuppression, having an impaired immune system due to other causes that are non-HIV related. So, for example, cancer or chemotherapy or other genetic or hereditary deficits of the immune system. Sometimes people don't necessarily develop antibodies to HIV because they've been treated for HIV so early. And there's a very few select people, number of people who don't develop antibody responses to HIV. False positive HIV tests, this is when a person does not have HIV, but the test is positive. This is why it is important to remind people that this first test is a preliminary positive and that occasionally people can have positive tests when they do not have HIV. We see people that have previously participated in experimental HIV vaccine trials, so where they develop some antibodies to HIV even though they don't have HIV. There's also a number of conditions that historically we do see that people can have a positive HIV test but not have HIV. These include pregnancy, autoimmune diseases, malignancy, and one of the more common causes, and we definitely see this, is people who have had a, quote, recent flu vaccine. Again, the time frame of this isn't exactly known, but it tends to happen weeks up to months after people have had vaccination. So some of these conditions are really common, as you can imagine. So again, it is important to remind people, and we'll talk much more about this in counseling strategies, but when they do test positive, is to remind them that this is a preliminary test, that it has to be confirmed before the diagnosis of HIV can be made. So management and treatment of HIV. Again, no one in this course obviously should be treating HIV. However, it's important to talk about what happens for education and counseling purposes when someone is diagnosed with HIV, or even when people may not have HIV. One of the things that oftentimes comes up is what happens if someone does have HIV and the process and the treatment options when someone does. So when someone is first tested for HIV, really one of the first things that we want to do is to confirm that they have HIV through the confirmatory process. What that involved is going to a medical provider who will draw blood, which will be confirmed for HIV. All confirmatory testing in the state of Rhode Island is performed at the Rhode Island Department of Health, and they do so on a weekly basis. When people are then linked to a HIV care provider, they will have an intake visit where a number of different assessments will be performed. This includes just a whole lot of counseling and education. We'll often do a whole bunch of baseline clinical and laboratory data. We'll ask patients to fill out a number of forms, etc. And then we'll talk about different barriers to care. Those are listed here on this slide, but we'll often do a lot of education counseling related to substance use, social support, mental illness, other comorbid medical conditions, food and housing security, and insurance. These are all things that we address within the realm of HIV, of providing adequate HIV care. We'll also check a number of baseline lab values. This includes the measure of the immune system, the CD4 cell count. We'll also check the viral load. We'll check a person's liver, kidney function, blood counts. We'll test people for hepatitis A, B, and C, perform cholesterol checking what's known as an HIV genotype. This is assessing for HIV drug resistance. And we'll perform comprehensive STD testing as well, including for gonorrhea, chlamydia, and syphilis. At the first visit or subsequent visits, we'll certainly address any red flags. Certainly there's things, if people don't have a stable place to live, the last thing that they may think about is being engaged in HIV care. So certainly we'll address anything that's urgent or anything that could present barriers for HIV care. We'll discuss management, treatment. We'll vaccinate people with a number of different vaccines, as well as perform a number of other health screenings and referrals. When people have HIV, they tend to follow up every 3 to 6 months. In general, as people become undetectable, and we'll talk a little bit more about that. When people are engaged in medical care and doing well, we tend to see people every 6 months. So that's twice a year. So people can really have normal, busy lives while having HIV and remain engaged in care. Every 3 to 6 months, we'll tend to also check the CD4 count, the viral load, to make sure a person's immune system remains stable. We'll check liver and kidney function to make sure HIV or the medicines are not affecting those organ systems. And we'll address any ongoing issues that occur over the course of care, such as substance use, mental health, as well as any primary care issues as well. HIV at this time cannot be cured. It can be suppressed indefinitely. The goals of starting someone on treatment are really to keep someone healthy, to preserve the immune system, to prevent any opportunistic infections, prevent progression to AIDS. The other thing, the last point there, is that getting someone on treatment also prevents HIV transmission. So in order to transmit HIV, you have to be exposed to, obviously, the HIV virus of a person. When someone's on medicine, the HIV can effectively suppress a person's HIV viral load to a level known as undetectable. That means that when we check their blood, essentially there's no measure of HIV in a person's blood. This actually means that the person is incredibly unlikely to transmit HIV. So the goals of treatment are not only to prolong and keep the quality of life for that individual person, but treating someone actually prevents HIV transmission to other people. This is why there's such a push to get people tested and treated as early as possible, not only to keep them alive and healthy, but also prevent HIV transmission to others. When do we start treating someone? Ideally, we start treating someone as soon as possible. Historically, there's a number of different, we let the immune system come down, CD4 count to different levels when we decided to treat people. However, the paradigm of when to start treatment is essentially that today we treat everyone whenever that they're diagnosed with HIV. Treatment of HIV in the early 90s used to involve taking many pills multiple times a day. There's stories where people used to set their alarm clocks where they used to have to take handfuls of pills every 4 hours. It was really a disaster. Now there are multiple one-pill-a-day regimens. The medications are so effective, they have minimal side effects, and we're really down to one pill once a day. These are some of the most common medications listed here on this slide, but really the treatment of HIV has been revolutionized by the ease and the simplicity of taking these medications. The good news is that for someone being cared for HIV in the United States is that you will never run out of medications. These are a list from a couple of years ago of the currently approved antiretroviral drugs for HIV, and there's more coming out every year. In other countries, some of these medications may be limited, but here in the U.S., we have many, many different medications for HIV. This is a life cycle of HIV. I'm not going to go through this, but you can peruse it. HIV basically infects immune cells, the immune cell being in green here. It enters the cell, it replicates inside, and then the HIV viruses are released from the cell. As I mentioned, really one of the goals of early treatment is to decrease HIV transmission. In 2011, a large study was done that was really hailed as one of the breakthrough scientific discoveries of the year. The concept was known as HIV treatment as prevention. And as I mentioned, what this means is that when someone is on medicines, they become very unlikely to transmit HIV. This has given a lot of us hope and it means that essentially just by diagnosing people and getting them on treatment, we can make a significant dent in addressing the HIV epidemic. This is the actual study for those of you that may want to actually look through it. It was done by Mike Cohen, who's a very famous investigator down at the University of North Carolina. But what they basically found is that for people that were taking medicine and undetectable, it had approximately a 96% reduction in transmitting HIV onward compared to those that were not on treatment. When we start people on HIV medications, we tend to use 3 drug combinations. It has been found that if we use only 1 or 2 drugs, that those people will tend to have a breakthrough of their HIV. Therefore, we tend to use 3 drugs. The drug combination tends to be composed of what's known as an NNRTI and an NRTI, and those 3 drugs come up with the heart medication. What not to use, we tend not to use one medicine, and there's also a number of other medication regimens that we tend not to use as well. Even when people take their medicines 100% of the time as directed, they may eventually fail treatment. This happens over a course of years. It does not happen in everyone, but it does happen in some people. And that is why it's important to follow up with your medical provider, and it's also important to check your viral load. Over a course of years, HIV may occasionally mutate to develop resistance to the medication that someone is on. When that happens, their viral load will spike back up. And usually what happens at that point is that the doctor will change the medicines to another combination of drugs that the person is sensitive to, and then what should happen is the person should become undetectable again. Again, in the United States, there's now a whole wide range of these medicines, and people generally have an unlimited number of medicines to choose from. How long are people living with HIV? So we have found that there is still the stigma and misinformation in the community that HIV is a death sentence. And we still hear that today. Every year there's a handful of people that we counsel who report this to us. However, with the medications now and with people who are taking the medicines, really the key point is that the average life expectancy for people with HIV is essentially normal. And this is a huge advancement over the last couple decades, is that people with HIV have a normal life expectancy. And this is one of the first things I tell people when they're diagnosed with HIV, because one of the most common things that we get is that people expect to die shortly or to have a reduced life because of their HIV. And this essentially is not true. And we'll end there. Please feel free to contact me. My information is listed on this slide. Happy to answer any questions. Certainly, if you have any HIV positive patients that you ever test for, please give me a call and we will arrange linkage to care. But thank you very much for your attention.